Good afternoon, everybody. We have an awful lot of people subscribed to today's webinar, the second in our series on the 10-year plan. Around about 500 people have registered for this webinar, so no pressure panel for this one. We had around 200 last time, so we've more than doubled. There's about 170 on currently, so there will be some more folks to come. I'm just sharing a page from a website, which I'm not going to intend to talk about, but just while people are kind of joining us before I introduce the panel. There is on digital.nhs.uk a web page which is updated. I think the last update was the end of May. And it talks about the app roadmap, but also the NHS App 2 high-level objectives. So I'm just going to cover the 2 high-level objectives while everyone joins the webinar today. So one of those is to improve healthcare outcomes or improve health outcomes, putting them in control of their own health and care and the health and care of those they care for, increasing their skills, confidence, knowledge and care capacity for self-advocacy, connecting them to health prevention services. Now, drive efficiencies and reduce burden is the second one. So freeing up time for frontline teams and reduce administrative overheads, for example, increasing users' ability to self-service, supporting operational efficiency, reducing operational costs, helping users get to the right place first time, designing NHS app services in a way that supports health system KPIs. Now, below that, and I will share this link in the chat afterwards, there is, it's broken down by health records, appointments, prescriptions, the same as the agenda on the left-hand side. It talks about some of the developments that they have made, some of the developments they will be making. There isn't someone from NHS England on this call. We nearly had someone, unfortunately they were unwell, but we will run a second webinar in this 10-year plan series, which will have some folks from NHS England. Whether it'll be exactly just them or others is yet to be decided, but we're in discussion with Alex Price-Falls, Vinda Varka, Helen Ming Tang, etc. So hopefully we'll get a representative on and we can actually hear from them where some of that development roadmap is going and what they've achieved recently. But I thought this was useful just to kind of start with. I'm going to stop sharing. I'd like to welcome our panel. So we have Martin, who's representing patients. We have Jackie, Simon, Penny and Daniel, who are all members of our networks, both from an NHS provision and also from core supplies into the market. Simon has 2 hats as a doctor, so he will be talking about his role as a clinician, and obviously Penny, although chair of the CCIO, and Jackie in the CNIO advisory panel, also work as day-to-day kind of clinicians. So with that, I'd actually like to start with Jackie. And from my side, I think it'd be really useful for people to get a bit of an understanding of where your organisation and some of your colleagues that you work with are with using the NHS app or not using the NHS app, and why that might be.
Hi everybody and welcome. I'm Jackie Cooper. I'm the Chief Nurse and Information Officer for Health Innovation Manchester and NHS GM, so 2 roles covering the entire landscape of Greater Manchester. In terms of the NHS app, I would say we are, I think as clinicians, delighted to let patients own their own data and understand and have some input into their own health and health outcomes. That's the entire aim. I think along with that comes some of the difficulties around the data that's inputted into the app and where that data goes and what we do with that data, and also the multitude of apps that are out there and how we're striving to get a single front door for those people in our communities who are somewhat confused with where they go to put their information in. I think there needs to be more work around integration, because actually the landscape is out there now and the apps are out there. So how do we now, with a clear drive to utilise the NHS app, how do we almost backtrack and find what's out there in order to get it to a single front door? And I think that's a huge challenge for us, for those who are dealing with the NHS app and other apps for patients, people to use to influence their own healthcare.
Jackie, super helpful. Simon, could I come to you in your clinical role, please?
Yeah, of course you can. So I'm Simon Eccles. I'm now the Chief Health Officer at Salesforce. formerly CCIO for the NHS once upon a time, and until October last year, practicing A&E clinician. I'm having a pause. I haven't come to terms with the idea I might have stopped practicing clinically, so I'm calling it a pause. But you've put up, Carl, the aims of the NHS App team, and they are absolutely right, and they're commendable. When this NHS App program was kicked off, whatever it was, 12 years ago now, the aims looked fairly similar. I would also add that I didn't necessarily see there's something about safety. I think it's an important aspect of the program that records are completely transparent to citizens. And yes, that's the single patient record and shared care records, but that needs to be reflected through the app as people's route in, and they act as their own quality assurance. A genuine anecdote for you was my wife being asked by her general practice whether she got an appointment to follow up a particular condition, and she said, I don't have that condition. And it turned out that it was her name at the bottom of a radiological report because she reported it, but it had therefore been appended to her notes. Now, those sorts of misfiling errors, patients are their best advocates for their own quality here. And then I just want one more bit that I didn't see, and I thought was surprising by its absence, which is citizen recorded data. So if we're really, and I absolutely fundamentally believe we are, empowering people to manage their own healthcare, and I think that's going to be wonderful. And the biggest change, the change in knowledge asymmetry between clinicians and patients. I would love to know what someone's pulse and blood pressure are normally. And huge numbers of people I don't, but wear a Fitbit or a Ring or whatever it may be that records this information, or they actually just take it and they note it down. But to know consequently whether that's someone, Martin, forgive me, of your age, or whether that's someone in their 30s, to know what their normal pulse and blood pressure is. And so they're not abnormal for a generic population, or the figures we have on our charts, which are by and large based on fit GIs from the post-war period, and we've never changed our tables. It becomes personalized to a level of 1. And if you're normally running with a blood pressure of 140 and you're now at 120, actually that's a problem. And if you're normally running with a pulse of 55 and you're now running at a pulse of 90, that's a problem. And we won't necessarily pick that up in A&E unless we're told about it. Your mood and mental health level, and that track over time, and your normal level of activity, so we can see significant changes in it, are going to become really important parts of the data. They don't need to pour into the general practice record necessarily, but they can sit within the app as a resource we can collectively call on.
Thank you, Simon. Penny, if I could come to you, same kind of question around the NHS App capabilities and how you're using it or not using it.
Hi, everybody. I'm Penny. I'm the Chief Clinical Information Officer for University Hospitals Coventry and Warwickshire, and I'm a very active clinician. I'm a consultant clinical oncologist. So for me, the NHS App ambition is really exciting, and it's very, very nice to see eventually that we are all converging to the same goal, patients, clinicians. We want to provide the right care at the right time, and we want our patients to have a choice. And from my perspective as a clinician, this is what the new NHS App is offering. It's offering information, it's offering choice. It also keeps us accountable as clinicians and as organizations, because now our patients they will have hopefully the visibility of seeing the outcomes and our outcomes, and actually make a choice of where they want to be treated. I think it's very important to say that access to therapies is going to be critical, and the fact that patients will be enabled to look at appointments, book appointments, and manage their own bookings, this is critical. And it will reduce the anxiety, I think, by awaiting investigations. At the end of the day, these are patient data, and they're entitled to see. I have had a patient only this week that presented to me with a result I couldn't see in my electronic record, and it was there. And they had the knowledge to come to me in clinic and say, actually, this is what happened to me 2 weeks ago. And that was, I thought, really, really powerful, made a difference to the care plan. And the patient knew and self-managed the situation really well. So I think there are lots of benefits, but we all work together. The crux is in the implementation of this, and it's in the design. And I'm very pleased to see in the report by Vin Divarkar that patients and clinicians need to work together to make that design right.
Penny, super helpful. Martin, I'd like to come to you. Martin represents patients. Martin, do you want to introduce yourself quickly?
Yeah, hello, my name's Martin Pickthall. I'm in the Humber region. I'm chair of my local practice's PPG. I've been heavily involved in IT for a while, particularly with the Yorkshire and Humber Care Record, from when that started. And that's where my background is. I'm very vocal about what patients need and what they actually get. At the moment, they don't get what they need. I'm very disappointed with the old NHS app because it doesn't really give you any help. The new one needs to get past all these difficulties. My main concern, being a mature person, is how are we going to get all the mature users actually to use it? A classic example is my next door neighbour who's 88. She doesn't have a smartphone, doesn't have anything IT at all, and there's no way she can actually use the NHS app. And we need to not forget, we're going to exclude them unless we include them all the way from the beginning. I know that will disappear over a number of years, but it's not an excuse for just doing nothing. My major complaint I have these days is called silos. Everywhere I go in the NHS, there are silos. There are clinicians, and I won't name any of the ones I deal with, who keep everything to themselves. They don't share. They don't want to share because it's their own little fiefdom and they want to keep it to themselves. They're going to have to learn that they're going to have to share. They're going to have to let everybody else look at the information. It's not theirs, it belongs to the patient. And until the law is changed to make it that the information belongs to the patient, not the hospital, not the doctor, that won't change because the practitioners, no disrespect to those here, will not change unless they're forced. And so that's important. Last little point at the moment, everybody talks about fixing appointments on the NHS app. You can't at the moment in my practice. My practice is relatively small. It only has a very limited number of doctors' availability. It has other professionals there who are really good and they're absolutely fantastic at doing what they do, but they haven't got enough resource. And again, this is the thing, all the resource has gone into secondary care and not enough into primary. So there's no way my practice could currently let anybody use the self-appoint, make their own appointments, because they'd be there for probably 48 hours every day with the number of people who do it. And unfortunately, again, one of the problems is that patients don't want to see anyone other than the doctor. So we have a very efficient form of triage in our practice, which is done on the phone, and that works. And the doctors are absolutely snowed under with people to see, but they can just about cope with that. But it's an area that you promise to bring it, but you've got to be very careful how you do it to make sure that it will actually work. As I say, I'm all in favour of getting the NHS up and working and replacing things like AirMid, which is the other one we use in this area. System M Online, that's the same as AirMid, but actually works on a main computer. And people don't want to change. My practice is trying to get everybody to go onto AirMid because it's better than what we've got now. But there's a huge resistance to change. Throughout my working life, that's been a problem, getting people to change. Patients don't like change because it upsets their everyday routine. Patients as a whole are very fixed in their practices. But as I say, where we're going with this, when we get there, I think will be fabulous. I'm very much in favour, but I'm afraid I still see a few stumbling blocks on the way. You know.
Martin, I think stumbling blocks is probably putting it rather mildly. We are fully aware, most of us, that there are regional issues here. People who are based in Derbyshire who might go to hospital in Jackie's area, their technology doesn't necessarily talk to each other. There's an integration issue. There is a money issue in terms of who pays for what and the tariff, etc. The NHS app is the reason why it's called the front door. Is it is a front door. It is a single sign-on. It is an opportunity to access multiple services rather than designing a central database function in itself with a single patient record, which is a separate function and a separate delivery model, which NHS England are working on as a priority alongside this. So a lot of the things that we would require as both as clinicians and patients are not in the NHS app as such, nor they ever will be, but it will be a central kind of matrix of access. So on that point around integration and what do we need to change at a technology and a local level, and I'd like to come to Daniel. Sorry to give you the hot seat there, Daniel, on this one, because I appreciate it's a big discussion. Just introduce yourself and what are some of the potential issues here about getting some of this to work and how we can start to erode into some of those barriers.
Yeah, so I'm Daniel. I'm the VP for Business Development at Seracor. Although the majority of my career I've spent in and around the NHS. I was at Connecting for Health for 7 years, the GP to GP programme. I've worked at various different trusts, as you can probably tell from my accent, in the north of the country, Manchester, Rotherham, to name but a few. My expertise is around data migration and integration specifically, although the organisation I work for also covers change management and a number of other things. I think very much like Martin was saying, it is that, you know, there's difficulties with making sure that people are using the app, whether that's access, whether that's you know, the ability to cover their needs. But I think there's two aspects of this that we need to separate. One, which is the single patient record element, which is going to be very much clinically focused, and there'll be clinical outcomes, and there's all sorts of issues around that. You know, a prime example that I've got is that when I worked in Manchester, a number of people received a letter that said they were addicted to substances. What they were was a smoker, but the clinical coding is classed as addicted to substances. So there's that element of making sure that, you know, just because we've got the data doesn't mean that just spewing all of that in front of a patient is the right thing to do, because there needs to be context, there needs to be understanding. So until we've got, one, the quality of the data in the right way to make sure that that's you know, the accurate data that's going across, and then two, being able to give that to a patient in a consumable way, that's the only way that we're going to be able to really get people to buy into their clinical record. But I actually think that probably more importantly and more useful is the administration aspect of the app. So people being able to book appointments, rebook appointments, see clinical letters, all of those things is separate to a single patient record or a clinical record. And I think that's where the NHS app really will get buy-in from consumers and citizens, because actually most people will only use an app if they're getting something from it, and the thing that they will get is access to a clinician or to a service, and that's the key thing that I think buy-in needs to happen. But some of us that are old enough to remember things like Choose and Book and other services, to be able to integrate and pass that data across the various different services is going to be a really, really tricky thing, because even within hospitals, there is different referral services, there is different booking services, how they are covered from a technology and process perspective are very different. So in some way, there's going to have to be a push towards standardization of processes, standardization of data, to allow that then to be surfaced into an application, even if we talk regionally or nationally. So that's going to be one of the really tricky things, is how do we make sure the data and the standardization of the processes is right before we start talking about surfacing any of that for patients.
Daniel? Absolutely right. And I think one of the suggestions from the centre is that they might focus on maternity. For those of you who aren't aware, there has been projects, trials, pilots on an e-red book. So for those of you who aren't parents, don't work in maternity, don't have children, it's a big red file that you carry around to appointments with growth charts, measurements, your details, your vaccinations, etc. People carry a physical copy around. Moving that onto an online system, one of the private sector providers behind one of those trials, unfortunately, went out of business. So that work has ceased. So I just wonder, on the question there, on an example of the e-red book, but let's say it's maternity service with access to the NHS App, how would that work based on some of the discussions that we've had there? So currently with the NHS App, we can't provide data into it ourselves as patients or clinicians. It's a read rather than a write to. What are the kind of things that we need to do as an ecosystem to enable this? Thank you, Simon.
Well, I saw that announcement and was there when Vin and Ming have both talked about it, and frankly it really puzzled me, because technically you can't slice maternity off from the rest of healthcare. So let's look at the two elephants in the room for a second and run at both of them. Right, one is the general practice record. And when the National Programme for IT started, I confess I was the medical director at the time, the aim was to have people's records transparent to that. And then that got stopped because of the access to GP records. And we went for the summary care record. And that turned into only medicines because of access to GP records. And we got care.data. And that got stopped because of access to GP records. And we got GP data for planning and research purposes. And that got stopped because of access to GP records. And now we've got FDP and the single patient record. There's a theme here. And if we aren't working out whether or not we're going to give citizens transparent access to the whole of their GP record, the rest is for the birds. Second challenge in this one is the full access to secondary care and indeed community care, mental health and other records. And that includes those really closed proprietary ontologies that are Epic, Oracle, Cerner and others, who will share to their own app quite happily, but won't share to the national app. And I know there's plans to sort that, and there's potentially legislative plans to sort that, but that, and I commend NHS England for grasping this. We've kind of got to get on with it. And we've got to do it against enough interoperability criteria. And Carl and others, you'll have heard me bang on about sort of CCIO 7. It doesn't matter, but there's a core set that people need to have absolutely transparent here. And those big players, if they're going to sell into this market, need to join in on making that data accessible. So I don't get maternity versus the rest. Next bit on that same one, as on elephant slaughtering, is IG. And so I've been reading some of the stuff in the chat, and thank you so many people for so many questions. It's just brilliant. But we kind of got to sort the information governance here out. The citizen, I think, has ultimate ownership and responsibility of whether their record is shared and what's uploaded to the app. And as long as that's true and easy, back to Martin's point, accessible to everybody, then kind of crack on. Because there was a comment about we can't let people upload their own data because that would be population level monitoring of people's health. Well, believe me, Apple and Fitbit and others have got millions, and we think our numbers are big. You start going to Singapore, you go to India, and you can look at really big numbers of people pouring in physiological data. But we need to sort the IG around adolescents just for a moment, just to do the safety piece there. And this interesting, a comment on sensitive information. The reason we don't currently permit access for adolescents is entirely down to safety, and the edge case given, and I completely understand it, is a pregnant teenager whose health or life may be endangered if others become aware that she's pregnant. At what point does that stop being a child's record accessible by parents and become an independent record only owned by that individual, that adolescent? I get the edge case, and it's really hard, and I understand that. On the other hand, every type 1 diabetic going through that really difficult transition from childhood to adulthood, and more than 50% of all mental health conditions start in childhood, they need continuity of record, continuity of carer, continuity of their own control, which I think digitally we're in a really good position to offer. So, Carl, you're asking what are some of the barriers? I don't think technical's a barrier here. Other nations have done it. We can absolutely do it. I have some views, we'll come on to them later. But I do think we've got to get full access, citizen control, and solve our IG worries, which tend to be professionals worrying about patients rather than patients themselves.
Simon, and you're right. There is a general rule on the NHS app that if you're between the age of 13 and 15, you have to apply separately with your local GP to have access away from your parents, but that only deals with the 2-year age bracket. Jackie, I'd like to come to you.
So I think Martin gave a really good point about the silos, and I always say this: there is nothing national about the NHS. Our population thinks that there is and presume that there is, but we all know who've worked in it for many, many years, there isn't. I don't know what Simon's put, I don't know what Penny's put, I might be able to see it somewhere, I might not see all of it. So the problem is, digital is the enabler to all of this. Digital does not resolve all of the many problems that we have. So whilst the 10-year plan is great and talks about digital all the way through, the big piece of work is how. How do we do that? How do we standardize? How do we get our operating processes aligned so that no matter where the patient or person touches a health or social care provision, we can see the information that is digitally enabled? And we are a long way off that. For those of us who've been around a long time, we've tried it a few times, haven't we? And we haven't quite got it right. But the appetite is still there. And actually the goal is the right goal to have. The how is what we need to decide. And we need definitely supplier engagement with I would say a firmer hand in that. Not would you, should you, and you will do this for us actually, because it's our data and our population's data, and this is what we expect from you. We need strong leadership with experience of people who understand the how to do it, and then we need a population who believes in us and trusts us. And actually what we know today is we've lost a lot of that. So we had it in abundance in COVID, and we've lost a lot of that faith. So getting the trust back of our population is really, really important. And part of that is effective cyber. And I think we would all agree that we are not where we need to be with cyber. So the investment in cyber has to come hand in hand with this, because the minute we, and I always say not if, when we start having issues, we lose the faith of the people then. And if we lose the faith of the people, they will never engage. Just a point on maternity, because I'm a huge, neonates is my clinical background for my whole career. So I've got a strong view on this. For maternity, and you know, I remember the digital red book, you know, I lived that, you know, that we didn't achieve. But what we know is we are not providing the right safe service for the women in our community. That the evidence tells us that. And some of that is because women float around a region and outside of a region, actually, because if you're going to deliver a baby, you're going to deliver a baby. And that doesn't matter if you're on holiday, if you're down the road, if you're in the next region, you're going to deliver. And it might be in 5 minutes, it might be in 5 hours or 5 days, but you're going to deliver. And if you land in a place that isn't your local provider, that clinician in front of you has very little information about you. So they are guessing what to do. You may be able to tell them, or you might have some information, but on the whole, you haven't got enough information to make the safest clinical decisions for that woman in front of you and for the unborn child. Also, there are safeguarding issues, because actually, unfortunately, some women with safeguarding issues and safeguarding of the unborn child will purposely float around a region to deliver because they know they can do that, and they deliver and they go, and we've lost that woman and child to a system then because we've got no data. So the importance of getting a minimum maternity data set in a digital front door solution is of absolute importance. So agreeing what that minimum data set is imperative. So let's ask the people, the obstetricians, the clinicians, the midwives, the neonatologists, what do they need? And let's get a minimum data set in. So no matter where that woman presents, you've got something to go on to ensure a safer delivery, a safer journey for the women and a safer delivery of the child. So we are currently doing a lot of that work in GM with our shared care record, actually. So before we get an SPR or we know what's going on with the SPR, our shared care record, we are looking at putting a minimum maternity data set in. So no matter where in GM that woman presents, you can see some information. And right now that's a sticking plaster. That's the best that we can do. But an SPR is the way forward. And my overarching comment is the plan is great. We all agree with it. The how is so much harder. And I don't think we've got that defined on how we're going to deliver.
Thank you, Jackie. Absolutely spot on. And I think this is part of the process, particularly when we don't have NHS England on the call today. And for those who weren't here earlier, we will set up a second follow-up on the NHS app with some NHS England representatives. But there is a group of people here that need to work together to make sure we get this right. In cross-collaboration, user experience, I could read off reviews of the NHS app and how appalling people find the user experience, but some of that is also expectation, which you touched on, Jackie. And I think people expect certain things, and therefore, when they can't have those, the trust goes downwards in that kind of service and where they'll be there. Maternity was mentioned, so which is why I brought it up. But I'd like to come to you, Martin, on this is going to be a phased approach. Whatever we discuss here, there's going to be a phased approach. There's not going to be a quick turn on of here's everything, here's a full patient portal, here's a full clinical portal in one place. So on that phased approach, Martin, from your patient's perspective and experience with the people that you work with, what are the kind of things that you would like to see prioritised on that phased approach for the NHS app?
I'm going back to my favourite word, silos. I think for me, that is the numero uno of all numero unos. You have got to make the system work, first of all, within a hospital and then within an individual region. I mean, we're lucky here in Humber. We only have 5 hospitals in our region that take everybody. And they are now tending towards using commonality and the same system. So we've made a little bit of progress on that. But the difficulty to me is getting past this, having information available for everyone and everybody using it. I can give you personal examples, not from me, but from people I know, who have to go to the hospital to see 4 or 5 different specialists. And they have to go 4 or 5 times to see different specialists, because they don't share the information one to the other and the systems don't allow it. And that has got to be right at the top of the list, because not only will you be able to do that, you might actually be able to persuade some of these specialists to talk to each other. And actually, instead of treating patients for a condition, they treat them holistically together, all of them working together to work out a classic care regime. A classic example would be someone I know has a heart condition. They also have real arthritis problems. They're also diabetic. They see all the specialists. They go regularly for their appointments, have all their checkups. And then one of the specialists changes one of the medications, and that then throws other medications out that they can't use anymore. And because they're not talking to each other, they're not worried and looking at what each is doing that affects what others are doing, you can get problems. My diabetic friend had a problem and ended up in hospital because the meds had affected her diabetic balance. As soon as they realised what had happened, it all got changed. And then they talked. That's wrong. They should be talking first and then changing things. And for me as a patient, that's what I want to see. I want to see the fancy word is holistic medicine. I want to see everybody treated as an individual.
Martin, so I think particularly that's that's the fundamentals there, the single patient record working alongside an effective NHS app, which is a whole nother conversation which we'll come on to, and I know there'll be strong views on that one. Penny, can I come to you in terms of your day-to-day role in terms of practicing? What is it that would make you recommend an NHS app to your outpatients when they've either had some service or waiting for service or an operation, rather than the way you do things at the moment or recommending other apps? And what do you think needs to happen in order to see some of those wins? And the benefits of Guideline 2 in the NHS app, I'm asking about in particular.
Yeah. I think there's a huge opportunity to standardize what we do. In fairness, I see patients using different apps and it's very confusing for them. And it's poor patient experience, people coming to different service providers in the system and each one suggesting a different portal. I mean, that cannot be it. It has to be one way of doing things. It has to be efficient and it has to be a good patient experience. So that for me is number one, why I would recommend the NHS app. But the app will be as good as the processes that we have in our trusts, right? So for example, in oncology, if the results of a patient suggest that they have cancer and it gets released on an app, but I get to see the patient very late because of our late processes, that will not align things up, will they? That will be poor patient experience. I wouldn't want to find out that result for me of my relative through an NHS app. I would like to discuss with the clinician. So how do we ensure that there is alignment between the data that's released and actually having access to an appointment for those critical results? And the other aspect, which I think it was mentioned, is how can our patients tell us their experience? How can they actually record the patient-reported outcome measures, the experience measures through the app? So we as clinicians actually get those outcomes in clinic, we can adjust our care and we can improve our services. And I would say finally, for me, it's an opportunity to actually practice prevention and self-management and actually tracking the health of individuals. There are health coaches now in the community, there are health coaches working with primary care. How can we use that workforce and those workflows to enable our patients to become healthier for the population as a whole?
Thank you, Penny. I think that's very useful points there in terms of just exposing data and the management that needs to come alongside that management of information. Super important. Daniel, I'm going to come over to you shortly, and a point Simon made as well around we've tried interoperability. The conclusion seems it hasn't worked. Maybe that is a little bit early in the commitment to interoperability. There's potential laws coming in place or mandatory changes in the legal responsibilities in terms of sharing, in terms of future procurement, but we know a lot of people have got old software systems which won't be affected by that. We could mandate centrally that we take all of that data, or we could maybe work on integration. I just want to come back on the digital side for a moment and just see, from what Martin, Jackie and Penny have said in particular, how can we start to change some of that through either integration or RIP from the centre, and how that might look and how it might work. I'll come on to IG data protection later.
Yeah, so, sort of putting on a point, 20 odd years ago, the technology was there around PDS, around, integration of HL7, transfer of care and all of those things. So we have the technology around interoperability now. To touch on Simon's point a little bit, when we talk about EPRs, most trusts have what's called a trust integration engine. So the data can flow between different clinical systems. And that normally means that there is a way of getting the data out of the EPR in an interoperable way. One thing that I think is key here is leadership. It's about mandating what we do and how we do it and really backing that up. Because, talking about transfer of care, for example, getting using a particular technology and getting letters to patient within certain timeframes, that was in the national contract, that if you didn't do it within a certain timeframe, you would be penalised for that. Now, certain things like COVID came along and some of those things were laxed, but really setting those international global standards. You know, we talked about maternity in GP practices and maternity in acute. Most GP practices still use Read 2. Most acute still use ICD-10. SNOMED CT should be the national standard of coding across every single clinical system, and it's not yet. And if we mandated it and gave proper carrot and stick around some of these things, the interoperability issues would start to move away, whether that's used from the central or from particular governments. And that is going to take leadership, whether that's local leadership to mandate those things within neighbourhoods, or central NHS England leadership. Now, we know sometimes, obviously, from NHS England, that mandate doesn't always land correctly. So I think actually within the new neighbourhood organisations and the way that we're going to structure there, it has to be mandated in their neighbourhood that everybody uses the same interoperability standards, the same coding standards, not necessarily the same clinical delivery. That is slightly different, but the data that sits underneath that needs to be standardised.
Martin, can I come back to you, please?
Yeah, I just want to take this a slightly different version. One of the major problems I find at the moment is when I see a specialist at hospital, they often use the patient knows best to tell me about my appointment and what happened and things like that. Great stuff. But my GP doesn't see that because it's not getting information from the secondary care into primary care. And that's a second issue about everything. It's all very well saying the patient's going to have access to it, but my GP, recently I had tests done for a condition I have, and it took more than a month for the hospital to send to my GP the information they needed to record about my care so that I could get my meds. And that is just not good enough. It's all very well saying we need to integrate everything. I don't argue with that, but we also need to get it so that it works for the benefit of the patient. In other words, that information in the system is fed to those around the edges who need it. It might be to go to carers. It might be to go to physiotherapists. In the case of pregnant women, certainly into the clinicians who deal with the pregnancy and the care of the child. But it's got to work, the whole information. It's this silos issue again. It's not keeping the information to yourself, making sure, and if necessary, being forced to give that information to anybody else who needs it. And I think that the management needs to ensure that that is done. Sorry, I'm really annoyed about this one.
Great sense, Martin. Thank you, Simon.
So, agree with all of what's been said, but part of this is how we're going to do it. And we've had we're getting into a bit of the how we're going to do it here, and the challenge has been, as Martin's rightly pointed out, that stuff doesn't flow effectively. And at the moment, the NHS app itself is both the portal and it's most of the sort of business layer behind it, and has become the rate limiting step. So, as I say, the NHS app's been around for over a decade, and we've now hit, I think, just under 10% of repeat prescriptions are done through the NHS app. If I went to any commercial organisation and said, after 100 million quid in 10 years, you'll have a 10% uptake on one of your core functionalities, that product team wouldn't survive very long. So how do we make the shift here? And in my view, I think there are three layers. There's the portal. Martin, you're quite right. If you've got Patient Knows Best and it works well for you, that's fine. If you've got the NHS app and that works well for you, that's fine. But back to Penny's point, you shouldn't need 4 apps to be able to manage your healthcare. You've got to have either your choice or the national offering. I think that decision, which wasn't made 5 years ago and needs to be made, just happens. Underneath that is the layer that coordinates it all, And then at the bottom is the data layer currently within the electronic medical record systems of all of our providers, whether that's primary care, community, and whatever. That coordination layer, in any other industry, you'd call it a CRM, and I apologize, I work for a big CRM company, I know this is the right, but that's fundamental to the choice, to giving people control, to ensuring communications go through their preferred method. So back to the people who are not digital natives, that's the layer that picks that up and goes, don't send them endless messages through the NHS app. They've asked to be contacted by post, or they've asked to be contacted by phone if it's urgent. Conversely, for those who are digital natives, that's the layer that says, yes, please, I want in-app notifications. I want as digital as possible. I prefer that route. And you hold it. You also hold a detailed knowledge about them. And very quickly, you understand their likelihood of turning up at any given appointment and the value and utility they're going to get. Right now, if you get a breast cancer screening letter and you miss it, we just send you another letter 3 months later. How do we learn from this to drive, in that case, our uptake from 63% up to its intended 85%? And if I'm on the CRM for just a moment, why are we as the NHS building a piece of technology using management consultants to do so at huge cost when we could buy one off the shelf for less than 1/5 of the price? And I apologize for that bit of proprietary ranting just for a second, but it's a really odd decision, and we need to make the money go as far as we can on enabling the changes in care.
Simon, good point. Jackie?
Yeah, whilst we're on about the importance of all of this, which is improvements in patient and person care, that's what we're in it for, that's why we do it. I think whilst the huge conversations are going on around what we do with a single patient record and who's going to provide that and what it's going to look like, there's proof of concepts we could do today, and one of those is end-of-life care planning. So that's something that we are fundamentally getting wrong every day. So a patient or a person completes an end-of-life care pathway, an EPACS. Really difficult thing to do. Lots of people presume that's a frail elderly person. Unfortunately, we know it isn't. Could be us. It's anybody. So it's a really difficult thing for a person to do with their loved ones, deciding how their end of life will end, where it will be and how they want to be cared. What we know is we get it wrong all day, every day, because there's no view of it. There's no central view of it. So actually, it can be in somebody's handheld, it can be somebody's EPR record. But actually, what we know is, again, a bit like delivering a baby, you can become really ill and go, be in last days of life wherever you are. And what we know is, if we don't see that record, that care plan that they've taken the time, effort, and energy to put their last wishes in, what we normally do is convey them to an ED, take them into an ED, and they inevitably either die in the ED when probably most of them want to die at home, actually, and we get that wrong all day, every day. And I always say it's GERFed at its best. You only get one chance to get that right. And whilst the person has died, the loved one, because we presented on this a lot, the loved one lives with it for the rest of their life. They never forgive themselves. I got it wrong. I shouldn't have phoned the ambulance. I ended up in hospital. My loved one died in hospital and they desperately wanted to stay at home. So what we could do is we could use the NHS app as a proof of concept to get an EPACS care plan in there. And for those of us who are already doing that, what we need is a jump off from the NHS app, because we've done it and we've built it. So enable a jump off. So it's a single front door in, but no matter where that person goes, you can see their end of life care plan. And we could do that right now. That I don't think that would take a lot to do. So we could start small whilst we're having those great big discussions about SPRs and shared care records. Let's try it now, because that's what we should do. We're failing today. We know that. The data tells us that.
Okay, excellent point. Just to continue on that theme, which is part of what good looks like for the NHS app. So in terms of what we would expect, it's one thing the centre dictating what they think is a priority, but what should our greater priorities be? Just building on that, Jackie, please, Penny.
So I think you stole the words from my mouth, what good looks like, really. And to Simon's point, I think there is a lot of leadership and knowledge and expertise within actually NHS trusts and within systems. And we need to learn already what has been done and what good examples and good use cases which have already been done and what we have done about it. How can we learn from what good has happened, and how can we pick up workflows like this, which absolutely agree, Jackie. End of life care is an excellent start. And how can we agree on those together so we can have a starting point? Otherwise, we will be here talking about those grand plans, but not actually putting them into effect. And leadership here is key, and there is a lot of capability on the ground in the NHS, and we need to go back to the basics, get it right first time. What is excellence looking like? Let's get our patients together, get our key clinicians together, design those workflows and do it in an iterative way. It might not be perfect the first time, but it will be an iterative process that eventually it will serve its purpose, which is to serve our patients.
Penny. And just to reassure you, Martin, I think one of the biggest anecdotes that came out of our recent summer schools was smash the silos, which I think people fully appreciate and understand is something that needs to be done. Daniel, just on your perspective in terms of what good looks like, what are some of the services that you think are in near sight that we could deliver, which would be a benefit to both clinicians and patients?
Yeah, I think some of the services, there's obviously a lot of applications out there around mental health, around things like insomnia and others that could be integrated, those services into the NHS app. On to Jackie's point, there's no reason why the NHS app couldn't be a front door and then jump off to other applications behind that. So we could deliver some of these digital services via the NHS app. And then once you're doing that, you can then integrate some of that information back into clinical records or pass information easier between those applications. And I think that's where we need to start off, is looking at what are some of the quick wins, some of the stuff where the technology is already there and we can already integrate it. Tech debt and legacy debt is going to be a massive issue, stuff that is sat in an inaccessible place, and that is going to take a longer period. But I think from a technology perspective, there's a lot of newer applications that are certainly there that we can certainly use, and picking up on some of those. But going back to a point I made earlier, is we need to make sure that we're actually making the NHS app accessible, usable, and something that patients want to use, and that they will get something out of it. Because if they're not getting anything out of it, then they won't use it. And then that's to Simon's point, is that actually, if people are not using it, then is it commercially viable to actually invest all of this money? So we need to make sure that we're addressing people like Martin's concerns, getting rid of the silos, putting things in there that will add benefits to the patients straight away that they want to see within the app. Not necessarily that us as professionals think that would be the best thing to put in there because we would like it. It's what do the patients want to see? What is the biggest thing that is missing from the NHS app right now that patients want in there? And that's where I would start.
Daniel, I think just coming on one of that point from patient experience, myself, family, I'm of a certain age where I have parents who are at the end of their kind of life, to be pretty honest about it, and children. We all experience that in our different experiences we have with healthcare. One of the things that patients have said to us at both events we ran at Rewired and personal experience is the frustration of a lack of information once they're already in the process and having to constantly call up their health provider, not knowing which one they should call, whether it's the GP, the consultant they've seen, the referrals, admissions, the home care, the OT, the OC, who's going to answer my question, when does it happen, what's the date, why has it been cancelled, why has it been moved? Now, if that's one of the big patient frustrations, and I imagine that's also causing a lot of cost and delay from a clinical point of view, how do we start to tackle some of that? And I appreciate we've only got a few minutes left. Any volunteers?
Well,
Simon?
yes. So, Carl, I absolutely agree with you completely, and I have a fear that we keep trying to solve it with a fully interoperable data lake, and if only we had a bigger lake and more interoperability, we'd fix it. And I don't think that's the right answer. We do need aggregation on demand, and we do need the ability of any piece of NHS data to be correctly associated with its citizen uniquely every time. So we've got the NHS number, but we don't use it in most hospitals. We also use a hospital number, and we don't use it in any emergency department, and that seems nuts to me. And it needs to be pulled through to you through whether it's single patient record NHS app, and you're then able to show it to people. So even if my electronic record at St Thomas's can't pull through Penny's oncology data for my patient, as long as it's gone to the patient themselves and they can turn their device around and show me, or Martin, if that's not the case for them, they can log in and display it, we're 70–80% of the way there. Within individual geographies, share everything subject to patients being happy about it. Jackie.
Simon, Jackie, can I come to you?
Now, don't shoot the messenger, but I'm going to say it. For some of the stuff, for the admin stuff, you know, AI is an absolutely great example to be more efficient. So if it was a patient or person wanting to know when this happened, when that happened, remind me of this. I'm not talking about, you know, clear clinical advice. That's not what I'm talking about, but I'm talking about a chat bot to say, remind me when this happened, can you help me with? So we have to be more efficient. We've got a strapped workforce, we've got huge issues currently in our NHS. We have to be more efficient, and we have to use AI in the right way. And I think a great example is to use AI for something like this.
Jackie, good point. We will have, as part of this series, a session on AI, so we will delve into that in a little bit more detail. Not just ambient AI, but the wider aspects of it and the data and the provision of that and how that might work and digital functionality. Penny, I'd like to come to you. We've only got a couple of minutes left. In terms of that kind of what good looks like, just a finishing kind of process from you in terms of where you think there's some achievements that are near side for us.
I think the healthcare industry has to catch up with other industries, like the way we can track, for example, a parcel in our app. Why can't we actually see where the appointment is in a queue? Okay, these are simple things that will make the lives of patients who are waiting, or the clinicians who are also anxious about patient waitings, better. So I think it's very, very important that we join our leading forces, our clinical leaders, our patients together to understand what matters and start from somewhere to start building the app to what it could look like in the future.
Hey, Martin, could I come to you for a final word from you?
I'm just going to say I wish everybody the best of luck, because it's not going to be easy. I'm all in favour of it, and I think that the patients who make use of the apps that exist, several of them, will be right behind you, but you've got to get it right first time round. Otherwise, you'll just lose everybody. They won't want to know. Can I just say that the point about the NHS number and not being used anywhere else, I take very, very, very strongly. I also volunteer for Yorkshire Ambulance Service, but I can tell you that they actually do pick up the NHS number if you call an ambulance, and it actually picks up in their system. So it is available to pass on to hospitals. It's just that the hospitals don't want it. Sorry, that was a side swipe. So
It's fine. Thank you, Martin. I think I've been here a while, and that single identifier has been a debate for a long time. And even the fact that the NHS number is so long, so most people don't actually remember it. And is there a different way to do that? I've also presented at a hospital where I've been registered with the local health number, and I've been registered with my NHS number as two patients, but I'm actually a single patient, and we were able to get that together. But, you know, those things are really basic things that need to get fixed if we're going to do this. Right, we are at an end. I'd like to thank everybody on the panel for giving up their time for the last hour. It's much appreciated. People do have day jobs, and we don't pay anybody to do this, so I thank you for your insights. We will continue to discuss this and the various elements. One of the things we need to talk about is the shift to neighbourhoods, the fact that take up in mental health trusts is particularly poor for the NHS App compared to primary care and acute trusts, but also that wider transfer of care and the charities that get involved in this, which are often overlooked. The third sector is often overlooked in these discussions. We will look at some of the technology like AI and some of the wider meanings, but that clinical safety, IG, cybersecurity are also often misrepresented in some of these discussions. And Jackie mentioned earlier, we will come back to that. Just one shout out from us. There are papers currently open for Rewired for people to submit what they would like to speak about. We will be shifting some of our content to reflect some of the 10-year plan and also the upcoming 10-year digital workforce plan, which will come out. So don't worry if it doesn't quite fit in. And patients, if you are out there, or patient associations, you want to get involved, please do submit. It's not just a clinical and supplier event. Thank you once again, everybody, and thank you everyone for joining us. We'll see you soon. Take care.
Thank you.